to discuss role of endothelial dysfunction in diabetic erectile dysfunction, a therapeutic target. Mr. Dr. A. Raveendran, specialist in internal medicine, Sultanate of Oman. So he has traveled a lot of distance from Oman to Ahmedabad to talk about this subject. Please, Dr. Raveendran.
First of all, I would like to thank Banshi sir and the team for giving me an opportunity to present this topic. Coming to the topic proper, I'll be discussing under the following headings. As we all know, endothelium is a monolayer formed by a monolayer of endothelial cells, and it was believed that it is a mere diffusion barrier. But now we found that endothelium have got an important role in various functions, including fibrinolysis, thrombolysis, maintenance of vascular tone, vascular permeability, platelet activation, and angiogenesis, etc. And these are the list of some of the endothelium-derived substance. You can see that various vasoactive substance which has got action on coagulation and fibrinolysis, growth factors, adhesion molecules, inflammatory molecules are produced from the endothelium. Endothelial dysfunction is characterized by impaired endothelium-dependent vasorelaxation. There are multiple mechanisms for this, but the reduction in nitric oxide bioavailability is the major pathophysiological process. And this is the diagrammatic representation of the same. So the mechanism is either by reduced nitric oxide production or increased nitric oxide scavenging. And these are the various steps of reduced nitric oxide availability in endothelial dysfunction. And we can assess the endothelial function by direct methods like invasive coronary flow mediated dilatation measurement, or non-invasively by flow mediated dilatation of brachial arteries, or by measuring the circulating markers of endothelium, or by non-invasive imaging techniques. And these are the diagrammatic representation of the various modalities to assess endothelial function. Coming to endothelial dysfunction in diabetes, as we all know, hyperglycemia, hypertension, dyslipidemia, all these contribute to endothelial dysfunction, which can subsequently progress to various atherosclerotic vascular disease and stroke. So the same risk factors and endothelial dysfunction, if it affect the penile vasculature, it manifests as erectile dysfunction. And people with diabetes are at increased risk of development of erectile dysfunction. They are 3 times increased risk of development of erectile dysfunction in people with diabetes. And people with diabetes usually develop erectile dysfunction 10 to 15 years earlier than those without diabetes. And as we already discussed, diabetes-related risk factors include glycemic control, poor glycemic control, advanced age, duration of diabetes, etc., and other comorbidities associated with diabetes. So in diabetic erectile dysfunction, vascular factors like structural and functional vascular factors, neurological factors which lead to impaired nitric oxide production, psychological factors, endocrine factors like reduced testosterone production, diabetes-associated comorbidities and complications, and polypharmacy. All these contribute to the pathophysiological mechanism of erectile dysfunction in people with diabetes. So diabetic erectile dysfunction is considered as a special entity. And in patients with diabetes, there is increased oxidative stress, increased reactive oxygen species, reduced nitric oxide production, and upregulation of raw kinase signaling pathways. All these lead to impaired endothelial dysfunction leading to erectile dysfunction. And the complications and comorbidities associated with diabetes like nephropathy, neuropathy, hypertension, obesity, hypogonadism, urological comorbidities, obstructive sleep apnea, depression, all these are common in people with diabetes, and these aggravate the pre-existing endothelial dysfunction and erectile dysfunction in people with diabetes. Coming to the relation between coronary artery disease and erectile dysfunction, a significant proportion of people with ED exhibits early signs of coronary artery disease. And the interval between the onset of erectile dysfunction symptoms and the occurrence of coronary artery symptoms is estimated to be around 2 to 3 years, and they usually develop cardiovascular events within 3 to 5 years. The arterial size hypothesis explains this phenomena. As we all know, atherosclerosis is a systemic problem, so all the major vascular beds should be affected to the same extent. But the symptoms rarely become evident at the same time. This is because of the different size of the arteries supplying different vascular beds. So penile artery being the smaller artery, it manifests early. Subsequently, other arteries like coronary artery and internal carotid artery and peripheral arteries develop atherosclerotic changes producing coronary artery disease, stroke, and intermittent claudications. So coming to the mechanism of erection, when there is sexual stimulation, it leads to release of various neurotransmitters like melanocortin and dopamine, and which activate the nerves, cavernous nerves, leading to increased production of nitric oxide, which is produced from L-arginine by nitric oxide synthase enzyme. And this nitric oxide uh, stimulate the guanyl cyclase, which lead to conversion of GTP to cyclic GMB, which reduces the smooth muscle calcium content, leading to smooth muscle relaxation and ultimately penile erection. And the cyclic GMB is degraded by phosphodiesterase 5 enzyme to 5-dicyclic GMB, and the cyclic GMB specific protein kinase lead to sequestration of calcium in the endoplasmic reticulum and other storage sites, and it inhibit inflow of calcium into the cells, leading to smooth muscle relaxation. Also, adenyl cyclase, which convert ATP into cyclic GMB, also reduce smooth muscle calcium content, leading to smooth muscle relaxation and helping in penile erection. Whereas alpha-1 receptor stimulation leads to detumescence and reduced erection. So the molecular basis of nitric oxide reduction in erectile dysfunction include presence of inhibitors of L-arginine, which is the substrate for synthesis of nitric oxide, like arginase 2, androgen deficiency, Rho kinase activity, advanced glycation end products, superoxide, and uh, uh, destruction of tetrahydrobiopterin, which is a cofactor for the synthesis of nitric oxide. When there is a vasoconstrictive stimulus, the intracellular calcium increases, which uh, sensitize the Rho kinase pathway, which helps in smooth muscle contraction, leading to loss of erection. So, coming to endothelial dysfunction as a therapeutic target for treatment of erectile dysfunction, the treatment of endothelial dysfunction is an approach to preserve or restore endothelial function, and control of various risk factors by lifestyle modification and control of risk factors like hypertension, dyslipidemia, and glycemic control all help to improve the endothelial function and thereby helps in reducing or improving the erectile dysfunction. So coming to the various pharmacological agents, the mechanism we have already seen, those agents which help to activate the neurotransmitters in the brain can help in improving erectile function. Similarly, those which provide substrate for the synthesis of nitric oxide or nitric oxide donors, or which activate the guanyl cyclase or adenyl cyclase, or which activate the potassium channels, all these can help to improve erection. Whereas the agents which can inhibit the degradation of cyclic GMB, that is phosphodiesterase 5 inhibitors or alpha-1 receptor blockers, can also stimulate erection, improve erection. So coming to the treatment of erectile dysfunction, PD5 inhibitors revolutionize the treatment of erectile dysfunction, and these are the various isoforms. There are 11 isoforms, and these are the inhibitors. So in patients on PDE5 inhibitor, it improves the endothelial dysfunction, and the common side effects include headache, and it should not be concomitantly administered with nitrates. And to diagnose failure of PDE5 inhibitor, patient has to receive minimum 8 doses of maximum tolerated dose of PDE inhibitor. And the common causes are inadequate patient education and incorrect usage of the drug, failure to optimize the dosage, and progression of the underlying disease pathology, or associated risk factors like endocrine abnormalities or psychological factors. So the treatment of failure include patient education about the need of adequate sexual stimulation, timing of intercourse, about the food interaction, duration of action, and optimization of dosage. And if one agent is not working, we can try with another agent. And those who are taking on-demand PPI, daily doses will be helpful. And control of risk factors and correction of testosterone deficiency and psychological issues also help to improve the outcome in patients with erectile dysfunction on PDE5 inhibitors. So other drugs include apomorphine, diazoxazine, which all improve the endothelial function. And transurethral alprazolam also increase the adenyl cyclase activity, thereby improving endothelial dysfunction. The intracavernosal injections of trimix, which contain papaverine, phentolamine, and alprazolam, also improve the endothelial dysfunction. Other agents which act on endothelial dysfunction include nitric oxide donors, soluble guanylate cyclase stimulators or activators, and raw kinase inhibitors, melanocortin receptor activators, potassium channel activators, and physical therapies like extracorporeal shock wave therapy and low intensity pulse wave ultrasound, which induce angiogenesis and neovascularization, thereby improving endothelial dysfunction. Platelet-rich plasma, which contain abundant growth factor, also improve endothelial function, and intracavernosal stem cells therapy also improve regenerate the damaged cells, thereby improving endothelial function. Other treatment include vacuum constriction device and surgical therapy, especially use of implants. Various antidiabetic drugs like metformin, pioglitazone, SGLT2 inhibitor, DPP4 inhibitors, and insulin help to improve the endothelial dysfunction, and thereby useful in patients with erectile dysfunction. And cardiovascular medications like AC inhibitors, ARBs, various antioxidants like vitamin C, N-acetylcysteine, beta-1 selective beta blockers like nebivolol, and calcium channel blockers and statins also improve endothelial function. So erectile dysfunction is a common male sexual problem in people with diabetes. Healthy lifestyle preserve the endothelial dysfunction, and various available medications are promising therapeutic option for people with erectile dysfunction. And this is the book recently published by Dr. Jyotideva Keshodeva and team. And I got an opportunity to contribute a chapter on sexual dysfunction in diabetes in this book. Thank you for your patient listening.